And it's still not entirely clear really what's driving these differences, but something that certainly deserves our attention and discussion. So with that, I'm really looking forward to the discussion tonight and ultimately thinking about how we as a group are going to better understand these issues and ideally change this phenomenon. So thank you all for being here.
Thank you so much, Dr. Benheim. And now we'll move on to an overview of the study by the two medical students who primarily worked on the study, Temi and Michael. Temi, you can go ahead and share your screen.
Awesome. And thank you for having us today. We're excited to be here and to share what we found in the study. So it's well known that across professions and career paths, females receive less compensation compared to their male counterparts. And prior studies have seen this in other medical specialties, and our study investigated the presence and origins of these disparities, specifically in neurosurgery. So the data set we worked with was the Medicare fee-for-service provider data set from 2013 to 2020. And to protect patient privacy, this data set consisted of services performed 11 or more times. And certain things that we were interested in looking at is experience, volume, and reimbursement. So we looked at years in practice. For volume, we looked at the services rendered, unique procedures performed, and the types of beneficiaries that were treated. And then in terms of reimbursement, we looked at the charges and payments. To adjust for the fact that we were looking at this across various years, we adjusted to 2020 inflation using CPI conversions. And then our statistical analysis was performed in R and using t-test, Wilcoxon rank sum test, and linear regression. So our first key finding from this study was that female neurosurgeons have fewer charges and payments compared to their male counterparts. So at the top, you can see the total submitted charges per neurosurgeon, and also looking at the payments per neurosurgeon, with females having less compared to men. When we did the sensitivity analysis, removing the top and bottom 2.5% of earners, we saw that this trend still held. So it wasn't due to having outliers. Next, we looked at years in practice, and we saw that this disparity increased with more years in practice, which was surprising to us. But we also believe that this trend may be because, one, there were less female neurosurgeons in the past, so greater chance of having differences just due to the populations looking at it. But we next we sorry. Okay. So next we looked at the overall Medicare practice metrics by gender. So again, we see that female neurosurgeons are performing fewer services, fewer beneficiaries, and have fewer years in practice. However, I'll get to more analyses where we hold these constant, and we still see that these trends hold. Okay, so here we looked at the different quartiles of pay. We looked at the services according to payment quartile, and when we look at quartile 4, we see that compared to males, female neurosurgeons' practice was made up of fewer highly reimbursing services. And when we looked at the unique codes by the classification, we also saw that their practice was made up of fewer things that were coded as procedural. However, something that is particularly of interest and concern is when we looked at specific codes and we held those codes constant with both males and females, we saw that even with the same codes, female neurosurgeons are receiving fewer reimbursements compared to their male counterparts. And this is particularly concerning because female neurosurgeons are doing the same work as their male counterparts. However, they're receiving lower reimbursements. And while some may try and argue that maybe the volume isn't the same or things like that, we're seeing here that when everything is held equal, females are receiving fewer reimbursements.
So good.
And so we thought that maybe this variation may be due to geographical differences. So we looked at the percentage of female neurosurgeons across different states. Again, here we can see that females are underrepresented in neurosurgery. However, when we looked at the effects of geography, we saw that geography did not play a role in explaining the reimbursement disparity between male and female neurosurgeons. Okay. So before I showed different codes that were billed, and we saw that within those codes, female neurosurgeons were being reimbursed less. And again, this is to drive the point home that even with the same code, female neurosurgeons are reimbursed less compared to their male counterparts per service. So from this, we saw that female representation in neurosurgery is increasing, and this is helpful. This is promising, highlighting better recruitment for women in neurosurgery. We also saw that female neurosurgeons are reimbursed on average 18% less than males when controlling for metrics including practice volume, number of services, and beneficiaries. While we did see that female neurosurgeons, a bulk of their practice is less highly reimbursing compared to their male counterparts, we think that another cause of the overall pay gap may be due to limited use of modifiers or complexity in coding. So this would be an avenue for educating female neurosurgeons to help decrease this pay gap. So limitations, this data set only included services from the Medicare population. And while there are some pediatric patients in the Medicare, it's not representative of all the scope of neurosurgery patients. Another limitation was that this data set only included providers performing a service over 11 times per year. So it may not include procedures that are done less frequently. And then in terms of future directions, we want to look at the role of practice setting, academic versus non-academic. We want to look at the influence of subspecialty, because we do know that female neurosurgeons are more represented in pediatrics, for example. We want to look at the participation in coding classes, for example. So do males have more chance to go to this compared to female neurosurgeons? Because we do know that oftentimes female neurosurgeons do bear the bulk of mentoring or are more likely to be called to administrative tasks or things like that that may take away time from participating in such coding classes. And future work is important and is essential to improving mentorship and retaining future female neurosurgeons. And I would like to thank you all for having us. We'd like to thank Dr. Chambliss for her insights in this project, and Mike, my fellow person that helped with this project, and we worked a lot with the analysis. And I would like to thank Dr. Eyre and Pitzlis for also having their insights today.
Thanks so much, Temi, and thanks for sharing all of that information. Dr. Chambliss will now speak on the trends that we're seeing and the importance of this moving forward.
Yeah, so I wanted to talk a little bit about, you know, the answer to the big question here, which is why. Like, how is this possible and why? And I want to really highlight the fact that Michael and Temi did all of this hypothesis production and data acquisition and data analysis themselves. And I was very fortunate in that they came to me with these results already in place, and they had done a very rigorous analysis. And they came to me to sort of help with answering the question of why and formulating a discussion around this and thinking about how we publish this data in a way that is going to be accepted, which is in and of itself an interesting story and an interesting challenge, right? So, you know, when they came to me with this, we got on a Zoom and we were talking about the data and looking at it. And I'll share a personal story, which was my first sort of hypothesis, and I think it is part of the problem. I ultimately have come to my own opinion is that there are probably two big buckets we can use to explain this discrepancy. And I think one of them relates to modifier codes. And the other may, and you know, this is purely a hypothesis, may relate to implicit bias on the part of coding staff. So I personally am a skull-base and brain tumor surgeon, and I've been in practice for 11 years. And at some point, maybe 2 or 3 years ago, my chairman, who is joining us today, which is awesome, I appreciate Dr. Thompson being here, came to me in my annual review, and he's also a brain tumor and skull-base surgeon, and we have very similar level of complexity in our practices. And he said, Lola, you know, he said last year I billed 1,000 RVUs versus worth of modifier 22, which is a modifier code that indicates a high level of complexity and comes with an RVU association and also comes with additional compensation. And he said, last year, Lola, I billed 1,000 RVUs, work RVUs of modifier 22 cases, which is appropriate for our practice. And he said, you know how many you billed? I was like, how many? He said, 0. And in our practice, we don't say in our op notes, hey, this is a modifier 22 case. We put specific language into our op note, and then it goes to a coder who assigns the codes, including use of modifiers. And so, I sat there and thought, gosh, I know our practices are of similar complexity. I'm clearly not saying the keywords that are getting to the coder to indicate that we should be coding for these appropriately. And so when Mike and Temi brought this data to my attention, it was probably 6 months after that conversation. And I thought, I wonder if I'm the only one out there doing it. Because at first I thought this is a me problem. And then when I looked at this data, I thought maybe this is actually one of those sort of gendered perspectives that actually, crosses through multiple people who come from a similar perspective. So I think one of our hypotheses is that it's possible that female surgeons are just more likely to undervalue their work or not necessarily, describe it as highly complex. And I say this based on simply my own experience of, I do a tough meningioma and I kind of walk out at the end of the day and say, well, meningiomas are tough, neurosurgery is hard, it's brain tumor surgery. I don't tend to say like, gosh, that was the hardest case anybody's done all week, and I sort of thought that was my own personality, but I actually think that maybe that is more of a gendered perspective than I anticipated. So that's one of the primary hypotheses to describe these findings. I mean, yes, we know that women do overall operate somewhat less. They have a lower volume than men. That does not necessarily mean that they're lazy or they're off doing other things. That may mean that they're just more conservative. And we know that actually women see patients in clinic more and for longer, and they see more, on a relative scale, they see more clinic patients. So I think they're maybe less likely to pull the trigger on surgery. But also they may be defining their surgery as average in terms of complexity and not excessively complex. And that could honestly explain the entire difference that we see here just in terms of the percentages. But I think that there may be more to it than that as well. One piece is who goes to billing and coding courses, who leads billing and coding courses. I found in neurosurgery, at least, our billing and coding courses are mostly attended by very new attendings. So people don't typically go during residency. They tend to go in their first year or two out of training or those last years of fellowship. That overlaps with a time that is a time of family focus for a lot of female surgeons as well, right? And I say this again anecdotally from my own experience, but I went to one billing and coding course and I was 5 weeks pregnant and threw up the whole time and attended like one session, which may also explain why I don't bill correctly. But I probably am not the only person in that position. And I think that it's sort of interesting to think about whether the overlap of our educational opportunities and our typical, the way that we offer those and the kind of typical path through which people attend those may affect women in a unique way. But it's probably not the whole answer. And it's important to say that this Medicare database does not include modifying codes. So we did not have a way to test that hypothesis or explanation. There are private databases, and the vast majority of neurosurgeons get most of their compensation from private players. There are private databases that are not publicly available that do potentially contain some of those codes. And I'm hoping that to gain access to one of those databases with the assistance of one of our residents who's getting his MBA to try to test that hypothesis. The other hypothesis I think that's worth talking about is the notion of implicit bias on the part of the coders. So in our institution, none of our surgeons do their own coding, and that's pretty typical. And I will say, despite myself trying to really rectify this issue, meeting with the coders, talking about this issue, trying to dictate the same things that my boss dictates, I still have not really closed the gap very significantly. And I do wonder if there's the possibility that our coders who are working for the institution and for us and want to see us do well, just are dealing with implicit bias of thinking, well, her cases are usually more straightforward, for example, or his cases are always really tough, really big. Those are long, big, complicated cases. Is there a component of that that's completely unintentional? I don't know. I think there's interesting experimental designs you could think of to try to test that, where you could just, create op notes and create an imaginary surgeon who's submitting them, and you could actually test real coders to see if that exists. Interesting potential subject. But I want to get into what other people think. Those were the explanations that we came up with to explain this data. And I would also just want to spend 1 minute talking about how you publish data like this, because it's going to be really controversial. And I was a little fearful that this would get out on social media and we'd have 700 replies about how women just don't want to do as many cases, right? And that's not the answer. Or women just don't want to do as complicated surgery, which is obviously not the answer. So we worked very hard to make sure that this was, iron tight. We included another author who's not on this webinar with us today, but was really important, Clemens Shermer, who is an absolute expert in coding, and is also a man, and is also a skeptic, I would say, is a friend of mine. So I asked him, we had already written the whole paper, and I asked him to come on and just poke holes in it and make it stronger unless he could find another explanation. And he did a really rigorous assessment of it and helped us from that standpoint. And I think, you think about where you submit things like this. Should they be submitted to a place with blinded peer review or not? Do you want to have our names visible or not? There's value to that in both ways. Ultimately, we opted to submit this to JAMA Surgery, and I think it's spectacular that it was published there because it gets a lot of attention, and we were very intentional about how we promoted it. I reached out to the WINS leadership early to say this is coming out, and I'd love for you guys to help amplify this and help me push back when there are uninformed comments of people that haven't read the paper necessarily, so that we're prepared to deal with those things and that this message really gets across. So I would say, from my experience as a more senior author now, it's just a delight to have people like Temi and Michael doing this kind of work. And then it's fun to help figure out how to make it be maximally successful.
Thanks so much, Dr. Chambliss. And I think we'll have a lot of talking points based on that. We have one more discussion we'll do with Dr. Eyre and Dr. Pilitzis, and then we'll move on to Q&A so we can go over those talking points. So Dr. Eyre.
Well, thanks so much. On behalf of Dr. Ayer and myself, we're excited to talk about this, and thank you to the group for organizing this really important discussion. So, you saw these numbers, and I just want to draw your attention when I think about these as, these are kind of normalized numbers, and you're looking at charge and payment for service. And if you look at total submitted charges here, this is based on, 1-to-1, so it doesn't matter what the denominator was here. Gosh, male colleagues are submitting a whole lot more charges than women colleagues. And I don't find this particularly surprising. I think with things Dr. Chambliss pointed out, there's differences in groups, and there's differences in how we promote ourselves. There's been all that literature on looking for jobs. And, if there's a list of things in a job description, in order for a woman to feel she's qualified for that job, she has to tick every box. And, sometimes, men will look at the list and they'll like have 30% of the things on there and say, oh, I'm qualified. And, so I think there's some, gendered responses that do occur, which may not be ideal on either side. And, I think what was interesting here is, some of this does end up coming out in the wash, because you look at these huge numbers, and then you get down to charge and then actual payment for service. And, so a lot is charged up front here. And, once we get down to what's actually paid, and again, I'm going from big numbers to little numbers, these are different. I do think it's important to point out that, when we look at the volumes, these are different things. And when we look at unique codes, these are different things. And, we're talking about the disparities here, and this is a really important point. But I also think it's important to recognize these issues when, if you're frustrated about your pay versus a colleague, just to make sure that you're meeting all these benchmarks that your pay is being based on, because sometimes, we put other things as important, and this kind of falls to the last thing we do. And, it really shouldn't be, if we want to be valued for the important work that we do. I think this was a really interesting part of this study when you're looking at these CPT codes, because now you're comparing apples to apples, as opposed to other things where you could have had some criticism about apples to oranges. And I like the way the paper was organized. So you started out with this, and it really was very well done. And so you get to, when you're comparing, like, this difference is still here. And, this is an important thing to think about. But again, getting back to the overall assessment of issues, and, I think the bigger thing here, we're talking about the specific data with CMS data and a pointed thing. But when we're generally talking about wage disparities, we have to remember, from the big thing, that volumes, this paper showed that volumes are different, that we have fewer unique patients as women. The high billing volumes are different. Practices may be different. Sometimes we spend more time in low RVU producing situations, and, fewer patients are being seen a year. And, just understand that when you're trying to improve your compensation, or understand why you're compensated the way you are. However, controlling for CPT pay still differs. And, I think to go more into Dr. Chambliss's points, a key thing here is who's doing the billing. And, I see many times when we're looking at resources, like, think about it, like, somebody, an administrative assistant needs some help and she's swamped, and, women are much more apt to be like, oh, don't worry, I'll do it. I'll handle it, just because, just of social norms in some ways. And so, who's doing it? Are you getting the same resources? Is your more senior partner getting a more senior person billing? If you're like not the squeaky wheel, are you getting a more junior person that's billing? And so I think there's some under resourcing that may occur that we can have some control over. One of the things you absolutely should do, especially in most practices where somebody else is doing your billing, is check it. So have a parallel Excel sheet checking your billing to make sure that the codes match. And this is absolutely essential because, this is, what you're taking home, and this is your means to improve yourself and improve your biller. You'll learn things in both directions, and then to have conversations. And, how many times have you had to, go through like E&M visits, and are you billing a level 4 or 5? And, these are such low RVU producers for us. I wonder if we should do something similar at our institutions with auditing of these more complex codes to figure out what's being, what's on the table. I do think, education about billing too is something that we need to make sure that we take advantage of, as, this again is absolutely crucial to equal pay. So Ellen or Dr. Ayer is going to talk about, some other strategies about modifier 22 and other modifiers that are, kind of real life tips. So take it away, Dr. Ayer.
Great, thank you so much. So we thought maybe one of the best empowering pieces is to share some of the details and basics of surgical billing so that you are hopefully more empowered to double check the work that has been done. And to keep in mind, we're just talking about professional fees. That gets translated into technical fees, i.e. CPT codes. We're not talking about the larger DRGs, et cetera here, just what gets pulled back to you directly as a surgeon. And particularly in neurosurgery, we're in a situation where many of our cases, you not only have to, it's appropriate, right, to report multiple CPT codes for a single surgery. One of the lesser known details about that is only one of those codes ultimately is the primary code. And so when you report multiple codes, so I'll use from my own deck of cards here as a functional neurosurgeon, I put in an implant for stimulation. There's usually 2 to 3 codes for electrodes plus generator. Well, only one of those gets counted as the primary procedure, and that's the one that gets paid at 100% of whatever it is their allowance is with the contract. The subsequent ones typically get paid at about 50%. So if you have a procedure that, say, many levels of very complex spine surgery or other cases where you could potentially report more than 5 codes, it's generally up to the insurance company to determine whether they're going to give you any credit for codes beyond 2 through 5. And oftentimes will require a very detailed review of the documentation to determine whether you're going to do that. Now, the reason that's important to understand some of that detail is that, again, as has been discussed, most of us are not the ones who are doing our own coding. And the coders should be aware, right? That should be part of their job to be clear on which code is the highest value code and should be billed as the primary one. One of the tools that often people will use is in their operative notes to list the highest value code, the one that you know is the most important, as first, so that it is more likely that that one by the billers also gets ranked as the highest value code. Every other code after that is going to have the spot 51 modifier added to it, which discounts the code. So you should also be aware that noting, if you are somebody who does stage procedures, that if it's planned well in advance that these are stage procedures and you've documented it as such, you have the potential to be paid 100% for both of those cases. But if you haven't documented that clearly ahead of time, a second procedure could be at risk as not being performed or as not being billed because it was within the global period. So if you can click. The other, I hope, empowering thing is this, discussion around important modifiers. So the 22 is technically increased services and generally requires some sort of documentation, explanation in your operative note to state what it is. Was it because of complexity of anatomy? Was it the duration of the procedure, what were the anatomical factors of, you know, somebody who's particularly obese, et cetera, that went into this being a higher level of service than what would be. And I'll admit here, Joe Chang can jump in because I think I saw him on here to correct me if I'm wrong. My understanding of the 22 code is that it is intended to be used relative to your own book of business. So somebody who has an incredibly highly complex set of surgeries that they're doing every single day, they should not be billing a 22 for 100% of those cases just because they have a more complex, right? That there's some relativity that you should be distinguishing what is the higher end of procedures for you. I'm not sure if everybody is doing that. Also need to keep in mind that there are times with bilateral procedures that the second side is considered a decreased billing. Reduced services, if you do something that's, you know, turned out to be way easier than you imagined, technically you're supposed to be putting that forward as well. If you have a unrelated procedure, so let's say you decide to go ahead and take out a lipoma as totally separate from the other surgery that you're doing, you can add that, and that actually improves your reimbursement. The other critical part that I think everybody needs to know is how to specifically document the work when you have an assistant, whether that is a resident, an APP, there's documentation, and you need to use the correct code for that. The other small tidbit here, and people can look at this later, is understand what means what is a co-surgery and what isn't. Some people tend to think that actually it works out so much better if you do a surgery together. In some instances there are that you ultimately end up with about 125% of the total billing, but for you personally that ends up at being 67.5%. So these are the details of that, and I'm certainly happy to share that further. So these are sort of the thoughts that that Julie had put together in terms of follow-up work that we should be considering.
So we were talking about, as was alluded to, there's a variety of ways to look at this. And, I think we can do comparisons at our own institution, as was mentioned. I think there's an opportunity for WINS to delve into this, to kind of try to identify what these issues are, to, really verify that these are the issues. I don't know, if it's possible because there's some regulations around it, but sometimes when you submit always when you submit your oral boards, you have to show what your billing was, and so that may be an opportunity and data already collected to see if some of our assumptions are right here. And I think maybe just testing people and seeing what groups of people would do if you even did like a little thing online to try to figure out how different people would bill different cases. And we wanted to kind of put these down as food for thought and to facilitate discussion. And with that, I'll turn it back over to Karen.
Thank you both so much, and ending with those talking points for discussion. So now everyone, we're going to stay in one large group for discussion. Please feel free to either put questions in the chat and I'll monitor it, or unmute yourself and feel free to ask questions to our speakers.
While we're pulling in some questions, I just want to say I love those ideas. Those are awesome ideas. And I think looking at that, looking at participation in coding courses are pretty low-hanging fruit. And I would love to see what I don't know if we have any, Julie or Ellen, are you ABNS directors? I don't know if we have any ABNS directors on the call, but I'd love to see what they think about the possibility of doing a research project looking at coding practices in submitted cases.
I also was wondering if Dr. Chang's still on, if he wanted to, he's, just a coding guru and has been. So I was eager to hear some of his thoughts.
I'm not sure if he's still on, but there is a question in the chat from Thomas. He asks, is there a difference in reimbursement rates between female and male surgeons within the same practice?
So I'd say we do not have that data from this particular data set. As far as I know, is that right, Mike and Tammy? So we did look at geography because there's actually differences in Medicare reimbursement based on geographic location. And so, that could be one argument made, is that women were just working in parts of the country where they receive lower compensation, and that was not true. But we don't have a way to directly compare within this data set. But as I said, there are other data sets that exist out there, including, the market scan data set that looks at private payers that we're interested in assessing this question with a similar methodology through. I also think it's interesting that we saw this difference in the gender difference was less when you looked at people shortly out of practice versus those that have been out of practice a long time. And yes, there are less female neurosurgeons in that group, but I also wonder if there's perhaps some improvement that's happening over the last few years in terms of people's access overall to coding education. And so we may see some narrowing of the gap, which I could certainly imagine is the case.
I love that, Lola. I saw that one graph where, it looked like the women were actually, in the youngest graduates, the women's trajectory was actually exceeding the men's trajectory. So, I think it's interesting too, in terms of why that's happening, and it's a great thing. Just to see that young graduates are getting this exposure.
I'll just add on to that, I wonder if there could be any role for additional administrative responsibilities or other uncompensated responsibilities that are increasing as you get more and more years out of practice. I know that's a conversation that comes up a lot, especially when we're looking at negotiating for jobs.
And it's interesting because you wouldn't think administrative requirements would really weigh on your individual per case billing, but honestly, they might. Because when we do, Dr. Politzis was just talking about, about auditing your own billing. And I will tell you that I did that a lot more when I had a lot more time on my hands. And the less time you have on your hands, the more likely you are to say, well, like nobody's forcing me to do that today. It's not on anybody's to-do list. So I'll let it go. Because the only person that it's really harming is me. As opposed to a lot of the other things that become important. Administrative responsibilities.
Although I would argue, hopefully, right, there's going to be increased shared responsibility across systems, at least for those. It's very different if you're talking about a system as you and I and several others are in, where the billing and the compensation are all wrapped into the larger, the hospital, the practices are all rolled together. But certainly in those situations, there is a significant onus on those who are doing the billing to really get it right. And we have to be responsible. I've been surprised over this last year or two. I've had people say, well, what about this? What about that? And I have pointed out that they've been getting an email every single week with what was billed under their name, and they did not look at it. And so there's sometimes where you're getting the information, but you need to be able to interpret it and then keep that conversation open with the people who are doing the administrative part of it on the other end.
So, I mean, Dr. Ayer and Dr. Politzis as chairs, it's good for everyone in the department to bill accurately. And what we're looking at here is probably largely underbilling, right, by female neurosurgeons. I don't think we're saying that there's necessarily overbilling on the other side. So it's better for the department, it's better for the institution, it's better for the individual surgeon. So what are ways that you guys look at making that relatively easy for the surgeons in your department? To that point, like they're getting the email every week. I get the spreadsheet and I'm like, oh, good Lord. I just kind of take a glance at the bottom line and it looks okay. How do you make that easy?
I would say, first of all, getting that information in a straightforward way. I don't know about Dr. Polizzi, I should say this, but it has not always been that way. And even a very small shift in how our reporting started out in the last couple months has confused the team members in terms of how they review that and are able to give feedback. So having a very consistent and transparent way in which you get the data, I think, is first and foremost. For most of us, it is a little bit, it becomes easier over time because most of us have whatever 70 to something % of things that we're doing that are pretty similar most of the time. Rather than needing to know hundreds of codes, you need to know what your top are. And as you get used to that, that makes that more efficient. And then it's just a matter of recognizing those different circumstances. I don't know, Dr. Polizzi.
Yeah, no, I agree with what Dr. Ayers said. And, then I also think some of it's practice, because I think sometimes when we see numbers and, it's not something we're normally looking at or don't know what to look at, like, a budget sheet. Like a budget sheet can be very intimidating if you don't know how to go through it. And, then once you do, it's like reading an abstract, like you get practice with it and you know where the key things are, and then it takes you a whole lot less time to look at it because you know where your eyes are going. And so, I think spending the time, learning to or practicing that, and just saying, okay, I know I don't really want to do this. I don't have time. I'm like, but forcing yourself, like, even to spend, whatever, 5-10 minutes a week, just so that you develop those skills, and then it progressively gets easier and you can find where things are, where opportunities are.
We have a question in the chat. Do you all have any advice for fresh grads negotiating their first job contract and possibly ways to avoid some of these inequities?
Yeah, I think you have to educate yourself. And then I also, and however you want to do that, I think is important. So reach out to people that know how to do this and can help you with the negotiations, because, that's the best time that you're ever going to have to get what you want and to make sure that, the contract is fair and has what you want in it. And, this is, this can be challenging in any job environment. Some private groups, this can be even more challenging because there's some details in there that you may not be savvy enough to appreciate as you're like just getting out in the world. So use senior people and their expertise to kind of look at this. And, I think there's also differences in, there's different subspecialties that bill better than other subspecialties. And so understanding in your group whether you're going to be pediatric neurosurgeon is going to be compensated for RVUs at the same way a spine neurosurgeon is it the same number? And if you're the pediatric person, that's probably not going to work out so well for you. So you need to understand some of those nuances. Go take a course, go meet your billers and coders so that it's a lot easier to, if you can, sometimes they're in like hidden, but develop a relationship so that you can learn and meet your reimbursement team and work with them to really like just make it part of your practice, just like you should collect patient data as you're getting for your boards, and you have to get that as part of your practice. I think train yourself early to do this.
And I'll say there's some notes in the chat here that I think speak to this particular point, which is that utilize templates as much as you can. When you get the right language down for a biller, these are jobs that probably certainly turn over more often than we do in our own jobs. And so when somebody comes in, is that somebody who already has expertise specifically in neurosurgery coding? They may or may not. So the clearer that you are and most consistent that you are in your documentation, the easier it will be for them to do the coding. And then coming back around and checking to see if there are any trends that you're noticing. I mean, I'll be honest, I had a colleague who realized just in a relatively short amount of time that a neurosurgical procedure that he does was getting billed as if it had been like an interventional pain procedure. And that's a game changer right there. So doing checks, also important.
In the chat, it said, looking at what a senior colleague bills and making sure, that's a great template because, they have experience. So trying to figure out what they do and not reinventing the wheel. I love the template idea. There's also, and sometimes there's mistakes that just get perpetuated, as Dr. Era was mentioning. The other thing about coding is, once you learn it, it's not like it's stagnant. It changes. So, I mean, remember, I'm going to date myself, but what was it, 5-7 years ago where, like the endovascular codes changed and, you had it like, that was like such a big deal. And so you have to stay on top of this and, get that information, from your administrator, and, yearly because things change.
And I will say there's good resources for that within organized neurosurgery. Organized neurosurgery actually does this really well. And I'm not sure that we're all taking advantage of this, myself absolutely included, because there are great coding courses out there that are like 2-day courses that are really from, bottom to top. And I think that's something that you should prioritize in early career. And I definitely wasn't at the right place to do that when I was in that point in my career. But then there's also coding update courses. So both AANS and CNS have, pre-meeting half-day symposia on coding updates where you've got experts that you can bring your own individual questions to, but they're also going to tell you what's new for that year, just to Dr. Politz's point. So I think that prioritizing attending those kinds of sessions is really, really key.
There's another question in the chat. Oh, sorry.
Go ahead. I was going to say, as a tangent to that, in terms of updates, when you are asked to participate in a RUC survey, do it. Right? That is your chance to truly give your input about what the work effort is that goes into the procedures that you do. It's not the time to try and tell everybody that you are the fastest, slickest person in the world. It is to a realistic assessment of the work that is involved. And if we aren't part of communicating that back to the powers that discern how many RVUs go with what CPT code, then that is somewhat on us. So if you get a request for a RUC survey, take it.
It will also take a lot of your time, so be prepared for that.
One of the questions in the chat was, how can we inspire interprofessional communication about, this topic? And, I think this is something that chairs could be helpful in doing, like obviously in thinking about this webinar and the article. It was interesting because today some of my mid-levels came to me, and there may be a disparity between what my female mid-level is getting coded and what my male mid-level is getting coded. And, so I think there's an opportunity to collect a little bit of data. And, I think we're neurosurgeons, we love data. Administrators love data. And, having that, I think is a way to facilitate the conversation to say, okay, here something's up. So let's do a deeper dive into that.
I wonder, just as we close out, not to put you on the spot, Mike and Temi, but I wondered if you guys would share any thoughts about like what you guys got out of doing this project, and anything that you learned or, was sort of unexpected or interesting to you.
I think going back to the diagram, looking at the disparities over the course of time, I think that was encouraging to me, seeing that the disparity was decreasing as we got to more recent years. And I know we've discussed possibilities or reasons for that, but I think it would be encouraging to think that it's because female neurosurgeons are being better educated on this, and hopefully as like me and my peers go on to be residents and then attendings, that gap would narrow even more. But from a data analytics perspective, it was cool because a lot of the data was readily accessible online, and it was just a matter of organizing it and using it to answer the questions that we were interested in. So this was a really cool project to do. It just involved getting the data online and analyzing it how we wanted. So that was nice.
Yeah, I love that. Like it just points to the fact that there's like a JAMA paper just sitting there readily available online. You just got to look for it, right? Mike, do you have any thoughts on that?
Yeah, I mean, I think
Thanks for
that
being the guy on the panel. We appreciate it.
it's an honor to be here. Seriously. I think for me, you know, like we had this project and we brought it together, and then just that one conversation that we had on the first call about that anecdotal experience, you know, of your own coding and how that drove, you know, the last efforts to get the paper to where it was, seeing how a real world experience really drove a big bulk of this paper was super cool. And then thinking about the impact, like, you know, I spent a lot of time in a basic science lab, injuring mice and watching how their astrocytes respond. And I don't get asked to talk a lot about that. So being able to come here and think about how the paper that we put together has some real world application is awesome.
Well, thank you so much, Temi, Michael, Dr. Chambliss, Dr. Aaron, Dr. Plitzis. Dr. Benheim is going to go ahead and close us out, but thank you so much, everyone, for your insight. Dr. Benheim.
Well, I just really wanted to thank everyone who was with us here tonight. A really special thank you to our panelists. Thank you to Mike and Temi for this really fantastic, you know, uncovering of this phenomenon, and to Dr. Chambliss and her team for pushing this forward. And thanks to Dr. Aaron and Politzis for being here and sharing your thoughts and wisdom of this. You know, my takeaways from this is, you know, it's really far beyond just the numbers of billing and coding practices. It's really a question of value, of valuing ourselves, valuing our own work, and then ensuring that we're using the correct language to make sure that what we are doing is being valued by coders, by our department, and by everyone around us. So, you know, doing further research to dissect, you know, what are the actual intricacies in this topic, I think is going to be fantastic. And really just being made aware of this issue, I think really gets us one step closer to the answer. So, so again, with that, I'd like to thank everyone for being here, and have a good night.
Thank you, everyone. And if you have time, there's a survey in the chat. Thanks.
Thanks.